like to invite up Carlos Hinojosa, who will be presenting on behalf of colleagues from Mexico City.
Thank you. Good afternoon, everyone. And I have to make a disclaimer to be using the code. I didn't know about the coding, but maybe in the future events I'll be in the proper coding. Thank you very much. It's a really honor that you accept this paper to be here. I want to make a public acknowledgement to Dr. Wollauer. Max Wollauer was our sponsor, academic sponsor for this presentation. And thank you, Max, for accept that. And I'm going to talk to you about this expression of peroxisome proliferation, activated receptors, PPARs, in ex vivo aneurysm tissue and how it is associated with arterial remodeling and inflammatory gene expression. This is part of the work of one of my team in Mexico City and part of a PhD program which is running by Javier Anaya and many other students that they couldn't make it, but maybe in the future they could show you more data about it. I don't have any conflict of interest. Everybody here, we know the importance of inflammation regarding the progressive of degenerative tissue, extracellular degeneration in the structure of the aneurysm, and how that inflammation interfere in the vascular remodeling, and those are key implications in the pathogenesis of AAA aneurysm. PPAR are nuclear receptors that regulate inflammatory and metabolic process. These receptors are very important, and we found something interesting. That's what I'm trying to. That's what I'm going to show you here, and we focus on that. Try to investigate how that relationship between PPAR and remodeling and inflammation genes in aneurysmal tissue compared with non-aneurysmal tissue. So we study along 4 years, 20 patients with open aneurysm repairs, and we did that comparison between non-aneurysmal aortic tissue has control in the same patients with those tissues with the wall of the aneurysm that were treated. We did the extraction of the RNA until the resolve method, and between transcription of reverse transcription using oligo-DT 1218 with the transcriptase through the method MMLB, we get the DNA and we get the solid structure of the proteins to process them, and the liquid phase of the RNA to study all of those. For have a good control, we normalize each of these genes and the process through the HPR3. We use this in real-time CPR, and we study the genes for the PPARs gamma, PPARs alpha, and PPAR delta. And as well, we look at the markers with TIM4, cathepsin S, and inflammatory markers with MCP1, TNF alpha, and interleukin-1 beta. All that was run in real time using the CPR. So we see that the PPARs gamma, alpha, and theta had a significant decrease in aneurysmal tissue, and in this percentage, which is very relevant, and measurement the comparison between groups, it was with a significant statistical value of P. This is our relevant slide, which showed that information in the first 3 graphs. You can see in green the control. Each dot is the tissue of each patient, and the asterisk, the stars, is the significance between both groups. And you can see how the PPARs are totally different in the control group, in the healthy tissue, compared with the aneurysmal tissue. As well, we can see how the TIM4 is completely different, and the inflammatory cathepsin, which increase the inflammation in the tissue, is highly in those patients. As well, other markers are relevant after comparing the MCP1, the TNF-alpha, and the interleukin beta, which is totally different. With that difference, which is relevant in this sample, we were very surprised how these remodeling markers were so important. The team 4 decreasing 64% in the aneurysmal tissue, cathepsin S increased 7-fold in aneurysmal tissue, and inflammatory markers had that increases in the aneurysmal tissue. That already we know that happens in the aneurysm. That's not new knowledge. We know how important is the inflammatory markers and the component that they have in the aneurysmal wall to those patients develop at the end the aneurysmal degeneration. The new knowledge is how PPAR are combined to or have a role, a very important role, which is associated with these increased inflammatory cytokines. The reduction of PPARs is very relevant, and unfavorably remodeling in aneurysmal tissue associated with this decrease on TIM4 and increase of cathepsin S are another important markers that contribute to this inflammation. The clinical implication, the activation of PPAR could be a strategy to reduce the inflammation and stabilize the aneurysmal tissue. If we know how to control and if we found something to manage the PPAR, could have an impact direct in the rate of extracellular degeneration and the inflammation in consequence. So that's the relevance of this study. In conclusion, these results confirm the inverse correlation between PPAR's gene expression and inflammatory cytokines mRNA, contained along with an unfavorable arterial remodeling gene expression, and this reduction in the expression of the 3 PPARs in the arterial wall. Tissue fibers, abnormal arterial remodeling, and production of pro-inflammatory cytokines. Thank you for hear this talk, and I'll be happy to take any questions.
Jeannie.
Hi, very nice presentation. I want to applaud you for having 20 open aortic samples to assess. That's really fantastic. We aren't able to do that very often anymore. I was curious, with having 20 samples, were you able to look at the relationship of size to the levels of your markers to see if there was a correlation with larger aneurysms, some of those going, at the more extremes of your range?
We have in the database, but because there is a very small sample size for make those clinical correlations, we don't have at the moment any significance or difference with the size of the aneurysm.
Hi, Carlos Rondalman from Stanford. Nice to see you again. It's interesting about PPAR gamma in particular. A few clinical trials have been attempted to look at agonists, have not shown any difference in the rate of enlargement or aneurysm disease progression. There's a lot of details in aneurysm clinical trials about, what's the appropriate endpoint and what's the right size to try inhibitor. But I'm just curious what you think, where this direction of this is going, given the experience in the past. Teddy trial, for example, used telmisartan, which was an agonist for PPAR gamma, and didn't show a difference. So your thoughts on that?
Especially gamma is more increased in those fat tissues, and is relevant just in there. For us, it was very important to see what is in the past in other publications, how this correlates with those agonists on inflammation and inflammation markers. I think with this, at this stage, with this sample, for us is relevant, and we need more sample size to look at other moderators and mediators that could contribute to make these results and prove, at least in our sample, that there is a significant impact or role at the end in the association with these other cytokines. I think could be another mediators, has medications or related to the patient that could affect other results that already have been published. Thank you for your question.
We have a couple more questions while he comes up. Do you want to go to the microphone? Yeah, while he makes his way over to the microphone. Do you think there's an interplay between the multiple different things that we need to target? Dr. Dahlman mentioned targeting gamma, but do we need to target multiple different things in different ways at different times, and we're not necessarily doing that?
Yeah, thank you for your question. It's very interesting, and hopefully in the future, using PET scans or SPECT scan, using another radio tracers, we can find at earlier stage the inflammation and how those patients could be treated. Because if we already found that these genes and receptors can modify the intensity of inflammation, and we found that through these biomolecular radiological studies, we can inhibit those and have a better result and anticipate the progress of the disease. Thank you.
Congratulations on some very compelling work. 2 questions. I was wondering where your control group came from, and whether that was age and gender matched. And then secondarily, I was just wondering if you, I appreciate it's just 20 patients, but if you were able to look at differences in expression in relation to gender, in relation to sex, as to whether, knowing the kind of differences with male versus female AAA behavior.
We do have more, thank you for your question, we do have more patients, women treated in our database. About, sorry, I say it in inverse. 20% of all patients are women, 80% are men. And the control group is the same patients with the same tissues. So I think that's a strength of this sample, because the same patient with the same characteristics, we only take in the side where we do the anastomosis, where there is no aneurysmal disease, for study the expression of PPAR in this tissue and the expression of the inflammation, comparing with the aneurysmal, which was not randomly, it was at the center, pretty much at the same level of the MIA in all the patients.
Got it. Thank you.
Thank you. Thank you very much.
Thanks to you.